Hi, this is Charles Gaba, creator of ACAsignups.net. This is the second in a series of videos explaining the basics of the Affordable Care Act and other healthcare issues in America. In my first video, I gave an overview of the healthcare situation of every member of the population in 2009, just before the ACA was passed and signed into law by President Obama. This time I'm going to go over the major problems which Democrats were trying to solve with the ACA, including a general breakout of major provisions of the law. So, to review, in 2009, the U.S. had around 307 million people, with about 84% having some sort of healthcare coverage of varying quality, while the rest had no healthcare coverage whatsoever besides the emergency room. The breakout was about 48% had employer coverage, 16% were on Medicare, about 18% were in Medicaid or the CHIP programs, 3.5% on the individual market, and about 1.3% in miscellaneous programs. And again, there were about 16% or 48 million people who were completely uninsured. So, besides those 48 million uninsured, what were the other problems? Well, in the employer or group markets, things were pretty stable for the most part. There were lots of exceptions, but the group market tended to be fairly stable, with the plans being fairly comprehensive for the most part. They offered guaranteed issue for eligible employees, and the premiums paid for by the employee themselves tended to be relatively low, mainly because their employer would usually cover anywhere from 65 to 85% of the cost. However, the group markets weren't perfect. They often had annual or lifetime limits on coverage. The coverage comprehensiveness varied widely depending on which company you worked for or which state you lived in. Many times only the employee was covered, not their family, who would have to seek healthcare elsewhere. And most importantly, the healthcare policies offered by some employers weren't comprehensive at all. In fact, they were often known as mini-meds or junk plans. Here's a typical example of what I'm talking about from a 2011 Kaiser Family Foundation article. McDonald's used to offer McCrew-Care benefits to employees, which was dirt cheap, just $56 a month for the employee, but it only covered up to $2,000 per year in total benefits, which is a joke. A single day in the hospital could cost that much alone, much less surgery, ambulance rides, medications, checkups, and so on. That's not health insurance. That's basically a discount coupon book. What about Medicare and Medicaid? Both programs have been around for decades and work pretty well for the most part, but they do have some issues. Medicare is a federally funded single-payer program. That doesn't mean that it's completely free for enrollees, however. There are premiums, deductibles, and copays involved, although they tend to be pretty reasonable. However, Medicare is not totally comprehensive. There are certain medical services which aren't covered, and in addition, Medicare doesn't have a limit on the maximum out-of-pocket costs to the enrollee, which is why there also exists a supplemental private Medigap insurance market to cover the rest. There are also some annual or lifetime limits on certain services under Medicare. So, why is Medicare considered financially efficient, more so than private insurance? Well, aside from more efficient administrative costs and the profit motive, or lack thereof, Medicare also only pays healthcare providers, doctors, hospitals, and so on, about 80% of what private insurance does. I should also note that a large number of Medicare enrollees are actually enrolled in Medicare Advantage plans, which are privately managed. Medicaid is also a single-payer program, but it's a bit more complex, with pre-ACA enrollee funding being split about 2 to 1 between the federal government and the states. This ratio varies depending on the average per capita income of the state. The comprehensiveness of Medicaid programs varies from state to state, with some being generous and others not so much. Medicaid generally reimburses providers even less than Medicare, with doctors and hospitals receiving on average about half as much as privately insured patients, although again this varies widely by state and service. This is a large part of the reason why around 30% of doctors don't accept new Medicaid patients at all. They simply don't feel they're being paid enough to make it worth their while when they could schedule a privately insured patient in the same time slot and earn twice as much. That brings me to the individual market, which is where the bulk of the problems were. Well, some states regulated the individual market pretty well before the ACA. For the most part, it was basically the Wild West. The plans offered were all over the place, had lots of fine print, obscure policies. They could cherry pick who they would or wouldn't cover by making you fill out a long list of medical history forms, and if they didn't like what they found, they could either deny you outright, or they would let you sign up but charge you a whole bunch more for the same policy than other people. Individual policies often had annual or lifetime caps on benefits, little or no minimum requirements for what had to be covered. what percentage of those services had to be covered, or how wide the provider network had to be. There was also a nasty trick called rescission, which came up now and then, where you might pay your premiums for months or years on end without getting sick, and then as soon as you're actually diagnosed with some serious expensive ailment, the carrier would comb through all your paperwork, find some incredibly obscure technicality on your forms, and kick you off your policy right then and there, right when you need them the most. Finally, again, many people who thought that they were enrolled in a full healthcare policy found out the hard way that they were actually enrolled in a junk plan, which wouldn't actually cover any significant medical expenses and were thus effectively useless. The ACA set out to solve many of these problems. The first major goal was to significantly reduce the number of uninsured overall by getting as many of those 48 million people covered through the other categories as possible. This was to be done through a variety of means, including an employer coverage mandate, by expanding Medicaid eligibility, and by completely overhauling the individual market structure, which included both an individual mandate and financial assistance. The second major goal, which overlaps the first, was to provide standard coverage requirements and consumer protections, mainly for the individual market, although some also applied to the group market, so that not only would as many people as possible be covered, but that the coverage they had would actually pay for the bulk of their healthcare needs without financially devastating them. So, in the Medicaid expansion provision of the ACA, before the ACA, every state had wildly different income eligibility levels for who could sign up. There were up to 8 different categories, depending on whether you were a pregnant woman, a newborn, a teenager, and so on. In some states, non-disabled adults without children weren't covered at all, no matter how low their income was. In states like Alabama, it was, and still is, just 13% of the federal poverty level. That's about $1,600 per year, or only $30 per week. Under the ACA, the idea was to expand Medicaid eligibility to everyone who earned up to 138% of the federal poverty line, or about $17,000 per year, regardless of their status. The federal government would pay 100% of the cost for these additional enrollees for the first 3 years, and at least 90% of the cost after that. However, in 2012, the Supreme Court ruled that it was up to each individual state to decide whether to agree to this program. So far, 31 states plus DC have done so. As a result, Medicaid enrollment has increased by nearly 17 million people since the expansion program began in 2014. Of this, at least 13 million is due to ACA expansion, while another 3 to 4 million are what are generally referred to as woodworkers. That is, these are people who were already eligible for Medicaid before the ACA, but either didn't know it or were reluctant to enroll until after the ACA expansion kicked in. Unfortunately, Republican officials in the other 19 states have so far refused to expand their program, leaving about 2.6 million people in the lurch, caught in the so-called Medicaid gap. These are people who earn too much to qualify for Medicaid, but not enough to qualify for financial assistance on the individual market, which I'll explain later. The ACA also created something called the Basic Health Plan Program, which is sort of a Medicaid Plus arrangement. These are private policies for people earning between 138 to 200% of the federal poverty line, but unlike Medicaid, which doesn't usually require any out-of-pocket payments, BHP plans do have a flat $20 per month premium, and that program is only available in 2 states so far, New York and Minnesota. These cover around 750,000 people so far. Okay, the three-legged stool. This has gotten a lot of attention lately, mainly because I've been promoting it to get it out there. The ACA's Medicaid expansion provision is fairly easy to explain. The ACA's overhaul of the individual market, however, is more complicated, and the best way to visualize this is as a three-legged stool. I didn't come up with this metaphor, by the way. An MIT economist named Jonathan Gruber did, about a decade ago, while helping design Mitt Romney's Massachusetts-based predecessor to the ACA, called Romneycare. The idea is this. For decades, the individual insurance market was based on insurance companies being allowed to cherry-pick their enrollees, only covering those who they thought would be profitable, that is, healthy people, and kicking sick people to the curb. The ACA changed the rules on this completely, and therefore, some other changes had to be made as well. Prior experiences about making this change in states like New York and Washington State taught some valuable lessons. If you're going to force the carriers to cover everyone and to have comprehensive policies, then you also have to include a carrot and a stick as incentives to make this work. The carrot is the financial assistance. The stick is the individual mandate. The first leg of the stool are the carrier requirements. Under the ACA, since 2014, all ACA qualified health plans have to include all the following: guaranteed issue, community rating, essential health benefits, a minimum 60% actuarial value, no annual lifetime benefit caps, and a list of preventative services. Guaranteed issue simply means that they have to sell to anyone who signs up as long as that person is able to pay. The carriers aren't allowed to ask about their medical history or condition other than whether or not they smoke. Community rating means that they can't discriminate on pricing based on their medical history either. In fact, the only pricing variation is allowed for under the same policy is based on the person's age, where they live, and whether they smoke or not. Older people can be charged up to 3 times as much as younger enrollees, and many states have more than one geographic rating area with different premiums. Smokers can be hit with a 50% surcharge. All ACA compliant plans also have to include 10 essential health benefits. That is, they have to actually cover medical needs like emergency services, surgery, hospitalization, maternity care, prescription medication, and so on. They also have to cover at least 60% of those benefits. Plans are broken into 4 different metal levels: bronze, silver, gold, and platinum, covering 60, 70, 80, or 90% of the enrollee's costs. There are catastrophic plans available as well, but those are only allowed for certain people. They cannot have any annual or lifetime limits on coverage. Before the ACA, a lot of plans might have, say, a $2 million lifetime limit, which sounds like a lot of money, but anyone who's ever had a premature baby born and who had to go in the neonatal unit, or is on chemotherapy, or requires expensive prescription medications knows that you can eat that up quickly. There used to be cases of preemies hitting their lifetime limits before they even made it home from the hospital. This is no longer allowed under any plans, either on the individual or group markets, by the way. Finally, every ACA-compliant plan has to cover a long list of preventative services at no out-of-pocket costs to the enrollee. This includes things like cholesterol screenings, mammograms, drug screenings, annual physicals, and so on. Okay, so you've got this leg, this blue leg, that has all the stuff that the carriers have to cover. If you're going to require all that to be covered, and that it has to be sold to anyone who can make the payments, even if they have expensive ailments, then that means that you also have to make sure that people don't try to game the system by waiting months or years to sign up, and then only doing so after they've been diagnosed with a disease. That would be like letting someone sign up for homeowners insurance after their house catches on fire, or auto insurance after they crash. If you allow that, the insurance premiums would quickly spike out of control, making policies unaffordable for nearly everyone in what's called a death spiral. That's exactly what happened in both Washington and New York. They both tried invoking guaranteed issue laws, and New York also added community rating, but that was it. Both states added one leg of the stool, but nothing else, and the results were a disaster. Premiums skyrocketed, and enrollment plummeted. With this in mind, Obamacare added an individual mandate penalty requiring people, with certain exceptions, to be covered with a qualifying policy, or they'd have to pay a financial penalty. Under the mandate, you have to be covered for at least 9 months of the year with a qualifying health plan, or you have to pay out about $700 a person, or 2.5% of your household income. In addition, the ACA includes a limited time open enrollment period. This is actually pretty standard among most employer plans, and it's also pretty standard in Medicare when it comes to changing plans. You're given a limited time window to sign up for or switch your plan, and once that time window closes, you're out of luck until the following year. There's exceptions for this for people who move, get married, have a child, and so on, but the idea is that they make you weigh the odds of getting sick or injured over a 9-month period against avoiding that risk by signing up during the other 3 months. Actually, this year, that's down to 1.5 months because the open enrollment period is being cut to just 6 weeks. Okay, so now you've got the blue leg, you've got the red leg. But you've told the carriers that they have to offer their plans to everyone, and you've told the public that they have to sign up for those plans. But now what about those who can't afford to pay for them? Well, that's where the third leg comes in, financial assistance. There's 4 provisions of this leg. Advanced premium tax credits, cost-sharing reductions, cap on out-of-pocket costs, and the medical loss ratio rule. APTC, advanced premium tax credits, are the best-known subsidy under the ACA. These are provided to people who sign up for qualifying health plans, or QHPs, through the ACA exchanges like healthcare.gov, Covered California, and so on, and who have incomes between 100 to 400% of the federal poverty line. That's around $12,000 to $48,000 for an individual. The formula for how these subsidies are calculated is complex, but it's basically a sliding scale as your income rises. It's based mainly on your income, but also on the actual cost of a typical healthcare policy offered in your rating area. That 100% lower end cutoff, by the way, is connected to the Medicaid gap problem mentioned earlier. The ACA assumed that every state would expand Medicaid, so there was no need to offer tax credits to those below that threshold. Since 19 states ended up not doing so, that means anyone below the 100% level is caught in limbo because they don't qualify for Medicaid, but also don't qualify for the exchange tax credits. I'll get to solutions to this and other ACA issues in a later video. Cost-sharing reductions, or CSR payments, are only offered to those who enroll in a silver exchange policy whose incomes range from 100 to 250% of the poverty line, or about $30,000 for an individual. These help cut down on deductibles and copays for lower-income enrollees. The cap on maximum out-of-pocket costs, or MOOP, also applies to deductibles, copays, and other expenses besides the premiums. I'm not familiar with the formula for this, but I know it's around $7,000 for an individual or $14,000 for a family before any subsidies you may qualify for. Once you hit that cap, the insurance carrier has to cover the rest. The idea here is to protect people from complete financial devastation in a worst-case scenario, so that as long as they're enrolled in a qualifying plan, there would be some sort of maximum cap on how much they have to pay. Finally, the 80-20 medical loss ratio means that at least 80% of premium payments in the individual and small group markets have to go towards actual healthcare costs, as opposed to CEO bonuses, junkets to Tahiti, marble staircases, and so forth. Anything over 80% or 85% in the large group market has to be rebated to enrollees. And while it's true that most carriers have complained of losing money on the individual market since the ACA was launched, some of them have actually done pretty well. And in fact, carriers have had to refund over $2.4 billion in excessive premiums so far. And that's the three-legged stool as it was ideally supposed to look. How it actually turned out is a little different, which I'll get to in a later video. There's a bunch of other stuff in the ACA as well, including the co-ops and other things like young adults being allowed to stay in their parents' plans until they turn 26, the ban on annual or lifetime limits and the requirement for preventative services on the group market, the closing of the Medicare Part D funding donut hole glitch, the extension of the Medicare Trust Fund by 7 years, Medicaid requiring essential health benefits, and so on and so forth. But I'll leave it at that for now. Again, this video was all about how the ACA was supposed to work. Next time I'll go over how well it has been working in practice, what's working, what isn't, why some parts aren't working, and most importantly, how to fix those problems. Until next time, this is Charles Gaba of ACAsignups.net, and again, if you appreciate the work that I do, please feel free to help out with a small donation. Thanks again, and talk to you next time.